So the other day we were just discussing fetal soft markers. I'll just continue with that. Now there are two acronyms. SOFT also stands for Support Organization for Trisomy, and then it's also a sonographic finding for transient nature. There is another support organization for trisomy 21, which is NDSS, which stands for National Down Syndrome Society. Now, when we talk about soft markers, there are two kinds of markers: hard markers and soft markers. So, soft markers are just a minor variations of unknown significance. Whenever they are present, they modify the background risk for mainly for trisomy 21. But if they are isolated, they are not a major determinant for predicting aneuploidy. But then there are some soft markers which are not that soft. We will see that. But before that, 5 of all the in the cohort of the population, there is 5% population which comprises there is fetal anomaly, and in that 5%, still 60% the cause is not known, and chromosomal abnormality is only 10%. In that chromosomal abnormality of 10%, there is around 50% is contributed by trisomy 21. Okay. Now, I just want all of you to focus on this key features of trisomy 21, 18 and 13. So there are a lot of overlaps between these trisomies, but then there are some salient features also which helps us to predict what kind of trisomy we are dealing with. So if we are aware of, like for example, if you are looking at the midline abnormality like holoprosencephaly, midline clefts and all, they are a strong pointer towards trisomy 13. If we see cleft lip, palate, micrognathia, so these are pointer towards trisomy 18, and trisomy 21 have got a lot of soft markers which we will discuss in the subsequent slides. So, and then there is biochemistry also which guides us as to which kind of trisomies we are looking at. Okay, so this slide is important because if you understand system wise, and when you see one marker or one abnormality, then try to look for the other and try to look for the third or fourth, because that if you can join those dots, it will help you to reach to a reasonable differential diagnosis. So you have to keep all those in mind. Now, why do you want to listen to this talk? Number one, soft marker is not equal to structural abnormality. So we have to be very careful when we are counseling. Soft markers like absent nasal bone, nuchal fold thickness, echogenic intracardiac focus, choroid plexus, cysts, ARSA, they are a potential marker for chromosomal aneuploidy. But other soft markers like echogenic bowel, single umbilical artery, urinary tract dilatation, short long bones, ventriculomegaly, apart from being marker for aneuploidy, they may also be a marker for evolving structural abnormality. Okay, so they need not be always a marker for chromosomal abnormality. They may be a marker for other evolving abnormality, like say there is a bladder outflow obstruction, or there is any obstruction in the urinary tract, that will also manifest as pelviectasis. If there is any kind of evolving skeletal dysplasia, that will manifest initially as a short long bones and then it will progress. Similarly, ventriculomegaly is just a sign of so many underlying pathologies. Okay, echogenic bowel again have got multifactorial causes, including infection, cystic fibrosis, growth restrictions, everything. So you have to keep our mind open that yes, these markers are markers for aneuploidy, but they may also be a marker for something else. So we have to be careful and follow up those pregnancies a little bit carefully. Now, how many soft markers are there? It is 9 plus 2. Now, I am not calling them 11 because there is a discrepancy between societies to societies. So I will just show you what is this 9 and what are the 2 additional ones. Now, isolated soft markers, if you see only isolated soft marker, you can offer serum screening or NIPS depending on your institutional protocol, depending on affordability of the patient. Obviously, we want your NIPS to be a first line, but if they are non-affording or I mean your institutional policy does not allow you to offer that, then you offer a serum screening, whichever. And if there are more than 2 markers, soft markers, then your first choice becomes a diagnostic test, and then second choice is your non-invasive prenatal screening. So be careful when you see one marker, then start hunting for the other marker, because if you see 2 markers or more than 2 markers, then your first line should be diagnostic test rather than NIPT. Okay.
Sir, if a patient actually it happened if a patient came from anomaly scan and quadruple test, and I found 2 around absent hypoplastic nasal bone and UTDA1.
Yes.
Single echogenic focus. Should we go for the quadruple test or directly
diagnostic test? Then we should discourage.
She went for the quadruple, came out high risk. She then again went for amnio and she came out positive for.
So it's always better whenever you see 2 or more than 2 markers, irrespective of the likelihood ratio. We will see the calculations and all, but irrespective of the calculations, better to give as diagnostic test as a first
cross guideline
line.
Is like that. If more than 2 markers, then
your first line should be diagnostic test.
Up to 2 markers, it's
2 or more than 2 markers, diagnostic test first line, NIPS second line. If there is only isolated, then whatever, NIPS or serum screening will also do. Okay. And once you have done, suppose NIPS you have done for that marker and comes out to be low risk, then that marker becomes irrelevant. Then you don't have to worry about those markers.
Has a high,
yes, that I will show you. That I will show you.
That suppose we are getting absent nasal bone,
Yeah.
should we go for NIPS or?
I will discuss everything. I'll discuss. Everything I will discuss. But before that, this paper, I think this was 2023 or 24. They have done study on 2,466 fetuses with ultrasound soft markers. So, and they have analyzed all these cases with amniocentesis and chromosomal microarray. So, what they found in this cohort of population, the prevalence of isolated fetal soft markers, isolated markers was 13%. Okay, they scanned all of this and isolated markers was 13%, and all of this, when it was subjected to chromosomal study, they found chromosomal abnormality was 4% only 4%. Okay, in this 4% there is 60-40. 40% was numerical abnormality and 60% was copy number variants, submicroscopic deletions and duplications. But those where there were multiple markers, okay, there this chromosomal abnormalities was even higher, like some multiple markers is 5.5%, or some markers which are very they are not that soft, increased nuchal fold thickness, there it was 8%, up to 8% numerical chromosomal aberrations. But by and large, multiple markers, the rate of chromosomal abnormality and copy number variants are much higher. That is why always, like we have discussed, when you see multiple markers, 2 or more than 2, you offer diagnostic. But what in diagnostic? Are you going to offer them a karyotype or FISH, QFPCR or microarray? Okay, so there you have to make a decision that what does the evidence is. So evidence is that we should offer as a first line chromosomal microarray, but then depends on the cost and the patient's uptake, but at least we should offer them a karyotype. Okay, basic. Now we will discuss this further, we will discuss, don't worry. Now screening models, these are the different screening models that we have discussed. So soft marker somewhere comes in the second trimester domain. Now the computation sheet. Now what do I mean by computation sheet? There are multiple markers. Now how do I know the strengths of the markers? These are all soft markers, okay. These are all 9 soft markers given in ISIOG. Okay, and all of us in the fetal medicine domain, we are following this 9 markers. Okay, now when we talk about soft markers, it's important to understand that not all markers are soft. In this category also we have relatively soft, relatively hard. So the top 4 with likelihood ratio as an isolated marker, see 6.58, close to 4. So 6.58 is for absent or hypoplastic, like Deblina she was saying. and rest are 4, up close to 4. Then you have in a yellow zone which are close to 1. Then you have in a green zone which is less than 1. So these yellow and green zones are relatively soft, we don't have to worry, but the upper 4 are not that soft. So we have to keep in mind, though these are soft markers, but based on the LR, likelihood ratio, they need special attention because they will significantly modify the background risk, because whatever is your X is your background risk, that will be divided by that LR, isolated LR, and you will get a new risk.
So how we actually take care of it? If we find
Yeah.
isolated soft marker among the upper 4,
Yes.
without any high risk report in NIPS or any other screening, then should we go for an invasive or not?
No, it depends on like Ankur, what are you, see, suppose you have a screening report with you. You have a first trimester screening report with you, and your screening report is say like 1:1200. Okay, 1:1200. First trimester screening done, 1:1200. She's low risk category. Fine. Now you found, okay, first trimester is common. We see that first trimester it has been documented, nasal bone present, everything fine. But when it has come to you anomalies, can you see no, nasal bone is absent? It happens very often. And please never ask your staff that who has done this scan, because it may be you only. So it happens. अरे कौन किया स्कैन देखो तो सर आप ही किए हैं. ओहो अच्छा ठीक है रखो. So this also happens. So careful, just very quietly see who has done. That's it. Now it happens because nasal bone is such a structure. Many times we get confused. Now what patient will say कि sir it was low risk 1:1200, but now absent nasal bone is 6.58. Suppose for simplicity of calculation I take it 6. So 1200 divided by 6 is 200. So now her risk, modified risk based on this marker alone is 1:200, which falls in high risk. So now you have to recalculate and put it in the report page that her final risk on first trimester this, but based on this her revised risk is 1:200, and now she falls in high risk category. So options discussed: number 1 diagnostic test, number 2 NIPS, depending on your
So
counseling.
NIPS was done and that
Yeah.
was low risk. Then what to do? And now I find the absent nasal bone.
Yes, even if NIPS was, I will come to that absent nasal bone, but even say like you have done an NIPT and you have got an absent nasal bone, NIPT result was low risk, you have to tell them that okay, it's low risk, less likely that there will be aneuploidy, but we cannot 100% rule out, so we may have to confirm it, but depending on your counseling.
So
But
I faced the situation.
this will happen.
Now we went for amnio. They told me from lifestyle they told me there is a QC, so we are not able to proceed with the CMA, and now they're unable to grow the cell for the karyotype. Now I've
Okay.
called the patient back to board. I don't know how to counsel. They asked for a repeat samples.
I will come to, there is one slide on absent nasal bone, I will discuss that. And but as far as these markers are concerned, we have to be very careful with these likelihood ratios, and then how they are calculated, we know that. So how soft, that depends on the LR of the marker. If no markers are present, then LR drops to 0.13 or 7.7 fold reduction. So suppose by this logic if you go, your suppose your risk is 1:500, now you are in intermediate risk category, but you are not finding any marker. So now your 500 will be multiplied by 7.7, so it will go past 3500, it will go close to 4000. So now actually she is not in intermediate risk category, she is in low risk category. That you have to explain to them. Then what happens, we know what does positive likelihood ratio means. Now we have to understand isolated likelihood ratio. You are seeing the figures. Now how that is calculated, you have a positive likelihood ratio. So suppose a marker is present, hypoplastic or absent nasal bone. So the positive LR 23.3, that will be multiplied by all the negative LR except short humerus. So all the negative LR means aberrant right subclavian artery 0.71 into 0.94 into 0.81, so on and so forth, except short humerus. So if you multiply, you will get the figure of 6.58. So sometimes it happens, like you are wondering how this that figure has come. So it is because of this positive likelihood multiplied by all the other negative likelihood ratio except short humerus. Now you don't have to put your brain in this because already you have a dynamic calculator, everything will be done, but at least we must know how those figures are derived. Now for example, I told you 9 plus 2, so this is 9 plus 2 is choroid plexus cyst and single umbilical artery. Okay, now I will show you what does different societies says. So ISIOG does not include choroid plexus cyst and SUA, but if you go for SMFM, they include choroid plexus cyst and SUA. They don't include aberrant right subclavian artery and ventriculomegaly. So there is discrepancy. So what does British guidelines like ISIOG says and what does the American guidelines like SFMM say? So why not combine both of them? No harm in combining. So you can combine 9 plus 2. That's why initially I put a slide of 9 plus 2. Now for example, say like you have two markers, aberrant right subclavian artery and echogenic intracardiac focus. So always I told you, whenever you see one marker, try to look for the other marker. And why aberrant right subclavian artery is important? Because this is not something you put the probe and you will see it. You have to make an attempt. You have to make an attempt, flow setting, angulations, and then you will see. So Dipti, if you realize these days only, we have seen two cases where it was undetected echogenic intracardiac focus and then we are seeing ARSA. So this happens, and why it is important? Because your risk calculation will completely change. Now if you use this calculator, which is a freely downloadable calculator, I suggest that all of you put it in your laptop. It is very helpful on bedside. So when you see these two markers present, your LR of combination goes to 28.69. So almost 28 times it will modify the background risk. So invariably, whatever your risk was, if you divide, most of the time you are likely to get your results in a high risk category. You are likely to get. So yeah, rest all are normal, just absent a hypoplastic nasal bone. Okay, no, sorry, echogenic intracardiac focus, first one, and then aberrant right subclavian artery. Okay, so those two are present. So this calculator will give you everything. Okay, you need not worry. Suppose absent or hypoplastic nasal bone and echogenic intracardiac focus, because these are all markers for Down syndrome. If you see this combination, then your LR of combination goes to almost 48. Okay, now this is just to show you how powerful they become when they act in combination. So they are very lethal in combination. So these soft markers, when they combine, they become very hard. So you have to be a little bit aware of those. Now I told you this is the SMFM consult series of April 2022, and this is a list of the markers. Okay, now you will see there is no mention of aberrant right subclavian artery and ventriculomegaly in this. There is SUA and other things in this. That's why I put that slide of 9 plus 2. Now we'll come one by one. Nasal bone. So whenever we counsel the patients with hypoplastic or absent nasal bone, there is a figure of 1 and 10. So what does this mean? 1 Caucasians and 10 Africo-Caribbean. So this is based on the race. So 1% case in Caucasian it is normal, and 10% cases in Africo-Caribbeans is normal, and Asians are in between. So you can say roughly around 6% or 1 to 10% cases it will be normal. I mean hypoplastic or absent nasal bone, and you baby will be absolutely normal. That is the problem with the soft marker. You will see in the normal population, and also it's a marker for aneuploidy. So you can give this figure. Now 60% of the case they are associated with trisomy 21, but a less number of cases they may be also associated with trisomy 18, 13 and Turner's. Right? Now hypoplastic equal to absent. Okay, so there is always a debate. People will measure nasal bone, they will say it measures 2.5, it is hypoplastic. Some will say no, I cannot see nasal bone at all, it is absent. So the definition of hypoplastic, if you look at the definition of hypoplastic nasal bone, it says if absent or less than 2.5 millimeter or less than 5th percentile or less than 0.75 multiple of medians. This is from the same article of SMFM. Okay, so what does this mean is there's no debate between hypoplastic and absent, they are synonymous. So you don't have to fight on hypoplastic and absent. So in my practice what I adopt is I either see absent nasal bone present or absent. I don't believe in that borderline and measure, because measurement error will be there. 2.5 millimeter or 2 millimeter, whatever you stretch the caliber, there will be a lot of inter and intra-observer variability. I measure something, Deblina, I will ask her to measure, she will say, no sir, I can see up till this point. So there will always be discrepancy. So why to do all that? Better we adopt a uniform policy of either present or absent. But this is my personal opinion, and this is the evidence from SFMM where the definition includes even absent also.
Sir, if more than 2.5 but echogenicity is quite obvious of having much lesser than the normal pattern.
Yeah.
But how will you
Less than 2.5 millimeter.
now more than 2.5
Huh.
echogenicity
See,
is
echogenicity they don't take into consideration, because echogenicity depends upon your angle of insonation, your harmonics, and there are so many factors, filtration factors, where it will determine the echogenicity. So basically that equal to sign which we are seeing, that is a kind of subjective assessment. We see, okay, there are two equal to sign is there, and we are supposed to see this bone more brighter than the skin. Okay, but then sometimes some variations will be there. Okay, and rarely they may be associated with some deletion syndromes like Wolf-Hershon or Cri-du-Chat syndromes also. So these all have been reported. That's why I was saying, Deblina, like we talk about trisomy 21 and NIPT rules out, matlab it's a very good for trisomy 21, but it cannot rule out for this microscopic deletions, duplications and all. And these things have been reported and it's there. So yeah, this is not that common, but these things are there. One of the case of even Anita Call, they got the similar kind, absent nasal bone, they tested karyotype and everything, and then it came out to be 4P minus syndrome. So these things may happen. These are all but rare. Now, if whatever you are saying absent or hypoplastic, and suppose there are two conditions where one condition FTS was negative, FTS is negative and you see that, then there are three options. One, you may just consider this may be a normal variant based on the races, so no further testing, or since it is have a very strong likelihood ratio, NIPS as a first line, or I am too concerned and then I say no, absent nasal, even if NIPS comes low risk, what will I do? Then I will go for diagnostic invasive prenatal testing, diagnostic test. So all the options you have to discuss with them. On the other hand, if you have done an NIPS and which is negative, which Deblina was just mentioning, so these societies, SMFM and ACOG, they say no further testing is needed. No further testing is needed. But this societies, if you go for the ISIOG says then you have to balance the risk based on your counseling. Okay, you have to say to them this is the likelihood ratio. It cannot rule out everything. NIPS is a screening test, it's not a diagnostic test, and absent nasal bone may have other chromosomal associations. So to be 100% definitive, we have to do a diagnostic test. This is ISIOG. But ACOG and SMFM, they categorically say no further testing is needed. So Deblina, still that is something we don't have the clarity on it, and in real life situation things are a little bit different. We cannot be very theoretical on in the real life situation.
So what about some referral cases for like unilateral nasal bone hypoplasia?
That is again, there is a lot of controversy in the unilateral cases. They report, and always this hypoplastic nasal bone, we have to look in two projections, whether we are seeing yes, that two dots we are seeing or not. Two dots we are seeing. Very rarely, I have not found very commonly that one side is seen, one side it is not seen. I don't know what is others people experience. So I don't believe in that unilateral only. If it is seen, seen. If it is not seen, not seen. But yes, you are right in that unilateral has been reported and it comes in reporting. But I heard Prashant Acharya saying once that if you see unilateral present, that means unilateral absent, right? So if unilateral absent is there, consider as absent. So go for the worst case situation and interrogate rather than thinking of that 50%, okay, unilateral present, so I should not do anything. Think of the other way, unilateral absent, so I should do everything, or at least everything on the paper. Okay, now I'll just show you the case example. Like, see, here you cannot see the nasal bone, okay, and this is just a reference image to show how nasal bone is seen. Okay, so when you are not seeing the nasal bone, you have to look obviously for all the other markers, but this case, this is normal case, but this case is the same. It was a monochorionic twin referred from Ranchi by Tulika, and this case also had agenesis of corpus callosum, and both the babies, monochorionic pair, had absent nasal bone. Okay, now it was a monochorionic MCDA. So we tested both the sacs. And since there was some financial constraints, we did a microarray high resolution on this baby and a karyotype on the other sample, right? And both the samples came to be normal. There was no association. Now next what? With agenesis of corpus callosum, we cannot encourage them to continue the pregnancy. Then we told, okay, now there is no problem on that other side. So problem is only on this side. Though chromosomally normal, but agenesis of corpus callosum will have neurological morbidity and other things we counseled in the terms of ACC. And then we told we could still go ahead and do a reduction for this by non-KCL techniques, RFA lasers. However, they went back to Ranchi and then they decided to terminate the whole pregnancy. So they terminated the whole pregnancy. They did not go ahead with this RFA, and though we wished, but they did not. They had something in their mind that, okay, with absent nasal bone, what will happen to the other baby, and if something else comes out and all those things. So they terminated. Now this was again you can see this whenever you see absent nasal bone, you would go for the premaxillary triangle, and the apex will not be closed, apex will be deficient. So always, especially with absent nasal bone, do in two orthogonal planes, because sometimes you may be fooled and you may be falsely saying, okay, this is. So always, whenever you not seeing in sagittal or the this profile view, go on that PMT view and try to demonstrate that apex is deficient, because sometimes it happens that you are not in a correct plane, just 1 millimeter here and there, then again you start seeing them. So this is one take home message, because you should see this PMT closed, completely closed. So I don't know, it's not only for the beginners, for even at whoever is doing, and even for the expert level also, we do the same thing, right? We always see that PMT and apex and everything. Now this was the study, most recent study of 2023, where they evaluated the value of second trimester nasal bone hypoplasia in predicting chromosomal abnormalities. And in this 351 cases of nasal bone hypoplasia are absent, isolated was 243 cases, and combined with other soft markers was 108 cases. But still in isolated cases also, you see total abnormality was close to 12%, whereas in associated it is close to 32%. So yes, we expect that associated ones will have high chromosomal problems. They will have more chromosomopathies if we do a diagnostic test. But even with isolated nasal bone hypoplasia, they found that 12% had chromosomal abnormalities. So that's why, Deblina, I was just discussing with you that even with isolated nasal bone hypoplasia with NIPS negative, we are not sure about the, we cannot assure them about the chromosomal normalcy, because this study categorically said that it is 12% they had even in isolated cases. So we have to be very careful with the copy number variants as well. So first line will be always microarray. Okay, now this you should always See that hypoplastic is equal to absent nasal bone, don't get confused. Now we will move on to the other soft marker, choroid plexus cyst. Now when you come to choroid plexus cyst, this is I think one of the commonest after echogenic intracardiac focus that we see. They are generally self-resolving and benign, but when I say but, it depends on the size. If the size is less than 5 millimeter, they are benign. But if the size is large, more than 10 millimeters, okay, in those cases you have to be little bit more alert, because those may be associated with trisomy 18 more often than not. Okay, so you have to be little bit careful if you are seeing a larger choroid plexus cyst, right? And also this larger choroid plexus cyst, they may hamper the functions of the choroid plexus, because choroid plexus there is function, they produce some growth hormones, okay, and then this growth factors helps in axonal guidance. So if the function of the choroid plexus is disrupted because of the mass effect from the cyst, the axonal guidance pathway will suffer, which will eventually may cause malformation of cortical development, which was noticed in this Palladini's paper, that isolated persisting large choroid plexus cyst should warrant neurosonographic follow-up. So with large choroid plexus cyst, even if you have done your chromosomal study, it comes out normal, please follow up a little bit more closely with neurosonogram, because in their study they have found those cases. Okay, so this was something new to me, and the differential diagnosis is, one is ganglionic eminence cyst, like this figure. If you see lower down arrow which is pointing towards a cyst, this is not a choroid plexus cyst, this is a ganglionic eminence cyst, because this is outside choroid plexus. So there are literature which says that look at the top one, ganglionic eminence cavitations, these are not choroid plexus cyst. So these are some of the differentials which you have to keep in mind. And the checklist, if it is isolated, it is isolated, fine, nothing to worry. But how will you reach to a conclusion that it is isolated when you have done this exercise? And what is this exercise? Look at the checklist, look at the growth, there is no growth restriction, look at the shape of the head, look at the face, if there is any cleft, micrognathia, so on and so forth, look at the heart, if there is any congenital heart disease, look at the extremities, whether the baby is opening or closing his hand or not. Because from one of the slide which I showed you, the markers of trisomy 18. So what are we trying to exclude in this is markers of trisomy 18, because we know this is most closely associated with trisomy 18. So you have to tick box, okay, I am seeing this, I am seeing this, I am seeing this, I am seeing this. Now I am fairly sure that no other markers of trisomy 18 I am seeing in this case, because 30 to 50% the cases of non-isolated CPC have trisomy 18, though it may be normal in up to 3% of the cases. And another marker which one of the paper says, that when you are doing a transcerebellar diameter, you do a TCD and then you measure the AP diameter of the cerebellum, APCD, and if your APCD by TCD is less than 50%, then it is a marker for, maybe, it's not sure, it is pointed towards, because in trisomy 18 there is cerebellar hypoplasia. So cerebellar hypoplasia, it affects the transcerebellar diameter and AP diameter both. So AP diameter is more sensitive marker for cerebellar hypoplasia. So if you take a ratio of APCD by TCD, so 50% is the cutoff. Rabichaud also in one of his lecture, he has mentioned about this. So this is not
more than 50% always of the
yes,
more than on the
yes,
high
more
side.
than
Less
then these are, so these are the soft things. So
hypoplasia both won't decrease, sir. TCD
no,
remains same.
APCD is a more specific marker for cerebral hypoplasia. So according to, I put this paper reference, no. So this paper there is is there in the White Journal, and there they have just pointed towards this factor, that it's a good practice when you see choroid plexus cyst, do an additional exercise. And Rabichaud in one of his lecture also has said the same thing, though this is not from Rabichaud's group. Okay. Now this is the case where you see this choroid plexus cyst, right? So this is this small or large? Yeah, quite large. So this, see this, So this case came to me as a second opinion for choroid plexus cyst only. So whenever case comes like echogenic intracardiac focus, CP cyst, so on and so forth, so we are very casual. Okay, CP cyst, we know it's benign, self-resolving. Just we'll put a probe and move and see the overall, right? But this case, when I was seeing, I think no, this choroid plexus is quite large. So something I don't know. I was not very sure, but this large choroid plexus cyst I have not seen too many times. So this was very discomforting. Like this near field ventricle, you see as if the entire ventricle is ballooned by this choroid plexus cyst. Okay. Now, what else? Fourth chamber was fairly okay, but when I was going in 3 vessel trachea view, I could see that there was narrowing of this aortic arch, transverse aortic arch. There is a narrowing. Okay, you will see this. The inflows were fine, but when you look at this 3 vessel trachea view, this picture you see this picture you see. I'll just show you this picture. You in grayscale, you will see your ductal arch and transverse aortic arch. Your transverse aortic arch is disproportionately narrow as compared to your ductal arch. Okay, but however the flow was antegrade, as the flow was antegrade. Just in the last image you see. Okay, so this case we did an amniocentesis and it came out to be positive for trisomy 18. So this case was positive trisomy 18. Actually this case went to I counseled for everything, but again as the patient does shopping and all, so they went to Dr. Kanchanda, and then he called me up and he told ki acha kya mila and all this, and then we discussed over phone and he said okay, fine. Then I told him ki okay, whenever the report comes please let me know, because I am suspecting, and also I have forgotten to put one more. It was persistently clenched it was. Face was fine. Fingers are persistently clenched. So I told, though Kanchanda told that no, sometimes he has seen baby transiently opening. I said maybe. When I was scanning it was persistently clenched, like that I told. And when the report came, he sent the report to me. So it was trisomy 18. Okay. So coming on to next marker, pelviectasis. So first we should understand that I think this part I have already discussed with you in the urinary tract dilatation, how to measure and all those. I will not go in that. This paper we were following this paper for quite a while, and it said likelihood ratio is 2.78 for isolated pelviectasis. So whenever isolated pelviectasis comes, divide by 2.78 to get a new risk. But later on it was realized that no, that is not the actual truth. The actual truth is isolated, if you are saying, the corrected likelihood ratio is close to 1. So isolated, it is not going to modify your risk anyways. So this 2.78 is obsolete. Don't go with this 2.78. Revised is 1. So isolated is 1. So we are not, it is not going to modify the risk. But yes, if it is present with some other markers, then it becomes significant. Okay. And whenever you see one marker, obviously you have to look for all the other markers. And the diagnostic test, that is little bit controversial. Isolated we don't offer, but if it is associated with other markers, then depending on the revised risk, we may have to offer a diagnostic test. And apart from this, there are multiple syndromes which are associated. So when you see this, carefully you have to evaluate not only the genitourinary system, the overall fetal anatomy. Like this case came to us at 23 weeks 4 days. In this, there was dilatation of the renal pelvis on one side. It was around 9 millimeter, and there was persistent left SVC. And because whenever you see, most of the time when there is persistent left SVC, you may get ventricular disproportion, because persistent left SVC may evolve to coarctation. So you may get. So I was very reluctant initially to send for to counsel them for amniocentesis, but then I said okay, persistent left SVC plus one marker, so we don't know. So I counseled. They fortunately agreed for invasive test, and then the invasive test result, this came out to be abnormal for trisomy 21. Okay, so this was related. I mean, I was a little bit surprised because it was not a very sure shot thing. So it was just a gut feeling. Based on that, we did, and it came out to be trisomy 21. Okay, now coming on to the echogenic intracardiac focus, we see it so commonly, and most of the time we are doing fetal echocardiography. This is a major business provider actually for the fetal echocardiography, echogenic intracardiac focus. But most of the time they are benign, transient, and when you see echogenic intracardiac focus, you do fetal echo because you have been asked to do. You cannot counter your referring physician. But instead of that, I mean, you do echo, but you look at the other markers because you know these are markers and you have to look for the other markers to modify the risk. So look for all the other markers. Only cases where it is persistent on the right side, literature says there is something to worry about, and this is the literature reference of 2024. Rest in left ventricle, they say nothing to worry about if it is isolated. Okay, though, and they are never associated with myocardial dysfunction or structural cardiac abnormalities. So there's no actual role of echocardiography, but okay, you may have to do. And sometimes if they are large echogenic intracardiac focus, then be a little bit careful with some of the fetal cardiac tumors. Okay, right, like rhabdomyoma or myxoma, because they may initially manifest with very small, tiny, bright looking things, and then later on they become big. So those cases of large echogenic intracardiac focus should be monitored little bit more closely.
So
Okay.
valvular orifice does not have a separate higher.
Yeah.
If the CIF is on the valvular orifice, I can see it's curved to the valve. Then does it have other significance also?
No.
Or it is just-
No. No. Septum, valve, free wall, things are the same. On right side, they said in this article that specifically is persistent on right side. They have found those cases are associated with some cardiac dysfunction on the right side, but otherwise they are mostly benign if it is isolated, and they are because of the microcalcification and fibrosis of the papillary muscles. Again, the recommendation is if FTS negative, you see this, no further testing, we don't do anything. And if NIPS negative, again no further testing. So this is straightforward. Now this is echogenic, this is aberrant right subclavian artery. Now this case also, this was a doctor case. This was actually amniocentesis done here, Dr. Ipshita. You must, I don't know, some of you must be knowing this. She came to us at Fitomet at around 30 weeks, okay. And previously there was only echogenic intracardiac focus reported elsewhere. So I was just doing a growth scan, and then whenever I see echogenic intracardiac focus, I try to look for ARSA, and I saw this ARSA, and then I said, okay, this is ARSA. Is that now 30 weeks? What else we can do? 30 weeks you are seeing ARSA. Then I still told her like, see, this is the thing, may be associated, but I am not getting any other markers. So then let us wait, or you may confirm by amniocentesis. So she then said, okay, she'll come back to me, but then she came back to Kushada, and amniocentesis with CMA was done here, okay, and the report was normal. Report was normal in this case. So so what is this aberrant right subclavian artery? It is normally, actually, right subclavian artery arises from the first branch, like brachiocephalic trunk. Then you have left common carotid and left subclavian. These are the three neck vessels. And brachiocephalic trunk actually is a combination of two things. One is the right common carotid and right subclavian artery. So sometimes in an aberrant situation, this right subclavian artery, instead of originating from the brachiocephalic trunk, it starts as a fourth branch from that arch of aorta, and this goes retrotracheal behind the trachea. So always when you want to demonstrate ARSA, you have to first see the gray scale, the confluence, and localize trachea, and then know this is my left, this is right. So this vessel from the confluence should go behind the trachea. So first with gray scale you have your mapping, then with low flow setting you switch on and try to see if there is any vessel from the confluence going behind the trachea towards the right shoulder. This is how I do. Otherwise, directly you put on color and low flow, everything will get mixed up. And sometimes this azygous vein, which is normally draining in superior vena cava, they may mimic as if some vessel is going into SVC or something, and then this is ARSA. So these are some false positives and false negatives. Okay, and again,
So what is trachea in that picture?
yeah,
Retrotracheal course.
ये देखो पहले what I do normally, like this picture, if you see,
Okay, got it.
saw na trachea, and in this picture, because it was 30 weeks, even in grayscale also you could see a vessel coursing. So this was not very difficult, because in grayscale also you are seeing a vessel which was coursing retrotracheal, and when you switch on, obviously everything will glow up. Okay, now if it is isolated, the likelihood ratio is 3.94. Okay, but if it is associated with echogenic intracardiac focus and plus ARSA, I have shown in the previous slides also, the LR jumps to 28, so 28 times more. So from 4 to 28, that means 7 times. Okay, so again you have to modify the risk, but important thing to remember is the significance. 1.5% of the normal population it will be seen. Okay, as per the meta-analysis and reviews and all, a lot of papers, they say 1.5% normally it will be seen, and it's a benign finding and very rare incidence of esophageal compression. They have not said it's a zero, but it's very rare to have esophageal compression. Important thing is, apart from trisomy 21, which is seen in around 1/4 of the cases, it may be associated with 22q11.2 microdeletions also. That is why when you are doing, when you are looking at ARSA, you will ask them ideally as a first line to go for microarray, because you also want to see that 22q11.2 microdeletions, right? Not only trisomy 21. And risk of congenital heart disease is 3 to 4%, and mostly those are conotruncal abnormalities, where you have to look for the outflow tract and thymus and all those things. But here you have to remember that in combination the risk jumps, and apart from trisomy 21, you have to also look for 22q11.2 microdeletions or vilocardiofacial or de Georges syndrome. Now this was the case again, just I am showing you, it's an old case. Again, this case also came as a echogenic intracardiac focus, and then here you can see on color Doppler, you can see the retrotracheal vessel. This was ARSA, and this was referred for anomaly scan. It was low risk, first trimester report, and normal mid trimester anomaly scan except echogenic intracardiac focus in left ventricle. But then we found ARSA, and then based on that, now see, if you have only, like say, if you have, this is a calculator, if you have only echogenic intracardiac focus, say present, your likelihood ratio combination is 0.95 with only echogenic intracardiac focus. This is normal calculator, everything is not known, but here you see top present, so your LR of combination is 0.95 only with echogenic intracardiac focus. That means it is not going to modify the risk. Okay, it is very benign. But when you see, now you have echogenic intracardiac focus present and aberrant right subclavian artery present, so risk, what did I tell you, it increased to 28 times. Now her initial final risk was 1:5,000. Now after detection of ARSA, it came out to be 1:174. So you have to mention everything in the report. Now the take home message is, look for all markers in case you find one to refine your aneuploidy risk. So 1:5,000 you don't need to stick in your needle. Why will you advise them for diagnostic test? Not even NIPT, nothing you will advise. But if you see ARSA, then see it changes to 1:174, it comes to high risk, where you will ask them for invasive test. So this is how your decision changes, right? Now when coming on to the short long bones by definition, some of the articles says 2.5 percentile, but by and large 5th percentile is fair enough, less than 5th percentile or 2 standard deviation below mean. And most common cause of short long bones apart from familial is small for gestational age. Okay, it's not skeletal dysplasia, so that comes later on in the list. Associations are chromosomal, in that trisomy 21, 18, Turner's, skeletal dysplasias, but then you will have other features of skeletal dysplasia. But important thing is to understand is 13% of the cases it is false positive, measurement error. So you have done a measurement, but it was, or the plane was not appropriate, and then again you call back after 1 week or 2 weeks, and then you say, okay, it's absolutely normal, it is coming within the normal range. It's not that the bone has grown, it is that our measurement was not appropriate. So calibration error also may happen. Significance, yes, 21% it short femur is associated with trisomy 21, but 6% in normal euploid fetuses also familial. Short humerus is better predictor, but will not go into all those debate. Now the recommendation is, if it is FTS negative, short long bones, but FTS negative, no further testing, or you may even counsel them for NIPS or diagnostic, because the paper which I cited to you in the previous slide, it showed that short long bones in their study had more stronger association with copy number variants. I will just show you this paper. It said that incidence of copy number variants was higher when multiple markers were present or when short femur group. So it sounds very benign, but sometimes you may have to just counsel them. Though with short long bones, I have never done a diagnostic test. I have not done. Only thing we do is we offer them an non-invasive test, and in that at the most NIPS, and then based on that, if it is negative, then nothing, no further testing is needed. But yes, we have to follow them longitudinally, and also we have to take the parental height into consideration. Right. Now single umbilical artery, important thing is first the technique, because sometimes if you are at 90 degree, you may not get a filling of one of the artery, and this happens. So you have to be little careful. If you are seeing single, then you just angle it little bit to make it to some angle, because you will see suddenly this is filling. And also this should be seen in two planes, one with this color and one with just without color. You see whether there are three, like Mickey Mouse or signet ring appearance, whatever. And this is how this is umbilical vein, and normally you see one vein and two arteries, but sometimes you will see just one artery encircling the vein. And these cases you have to be little bit careful, because apart from aneuploidy, there may be marker for adverse pregnancy outcome, and most commonly FGR, right? And if it is SUA plus some structural abnormality, they are pointed towards trisomy 18. So as we know, or whenever we see SUA, we do whatever we want to do, detailed structural evaluation, echocardiography, everything we do. But important thing, always we follow them very closely. Like normal pregnancy, suppose 6 or 8 weekly you are following this pregnancy, I prefer following it 4 weekly to look for the growth, because in my experience most of the time I have seen growth related issues only. I am not seeing single umbilical artery and then suddenly in echocardiography something comes out. If you are doing a good anomaly scan, things will be same, it will not change. Only thing what will change is the growth. Okay. So I remember a case from one of the clinician here. They sent it for reduction, and I did the reduction, and then 2 babies were following up, and then one baby started showing growth restriction, and there was single umbilical artery in that baby. Okay, and it started showing growth restriction, and that growth restriction progressed. So that clinician called me up and said, "Ki, I think you should have screened for single umbilical artery before reduction also, because then that would have allowed you to reduce the baby with single umbilical artery." But those things are retrospective analysis. Prospectively, how many first trimesters we are sure that I have looked at this? If you see 2 vessel, you know this is normal. But if you see single vessel, then I just try to ignore that. Okay, later on we will see. Correct na? We don't put so much of effort, and especially in the reduction, that single umbilical artery. But that case happened, so the clinicians retrospectively they will say कि अरे देख लिए होते सिंगल अम्बिलिकल आर्टरी है तो शायद उसको कर देते, तो तुम नेक्स्ट टाइम से देख लिया करना. I said yes sir, देख लेंगे. What else we can say? Is not, but I am not seeing anyways.
So this doesn't change the ratio. No? There is no related likelihood ratio. ratio for
No, no, it doesn't change. And again, the same thing, nothing needs to be done, and third trimester will follow for the growth. Now, nuchal fold thickness is something which is a little bit tricky, and it is also relatively hard. Now, what is this? Actually, why I have shown this first picture of nuchal translucency in first trimester. We don't measure nuchal translucency that way, obviously, but now a recent article has come which has said that in axial plane also, if you measure, is the same like how we do in the mid sagittal plane. Okay, and that was the reason why nuchal translucency was extrapolated as nuchal fold thickness in the second trimester, because it was by Beryl Benisaref. When he discovered this, then he said, okay, it's a thickness. So the same thickness, why don't we see in the second trimester? And that nuchal fold thickness evolved. Now, there is a way how to measure it, okay? Because most of the time when it comes for as an increased nuchal fold thickness, they are wrongly measured. And those cases which are actually truly increased nuchal fold thickness, you start seeing they are very gross. You don't have to measure them. You don't have to measure them. They will be gross, septated, or sometimes you will feel already hydrops is setting in, right? There will be subcutaneous edema and everything will be there, septations, everything you will see. So you don't have to measure them. The cases where you are measuring, they are not abnormal. Then there yes,
I find it increased.
yes, they are measurement errors. They are measurement errors. So anyway, but you should know that technique, and always should be little bit tilted, because you should not see the shadowing from the occipital bone. Isolated nuchal fold thickness is seen in up to 2% in euploid fetuses, okay, but it may also be seen in the sex chromosomal aneuploidy. And if it is associated with other markers, see, if it is isolated, 4% cases of trisomy 21 it will be associated, but if it is associated with other markers, then the association with trisomy 21 goes as high as 26%, right? And it is also a marker for congenital heart disease. Like you have seen increased nuchal fold thickness, you have done a genetic analysis, karyotype, everything has come normal. Still, you should be little bit careful, because it may be one of those cases of congenital heart disease because of the circulatory disturbances it is creating, that edema effect. Okay, those things are rare, but okay, but no harm in knowing about them. Now, one of I think last few slides only. This echogenic bowel, most of the time they are transient, and classification is not important. People will ask you in the panel discussion, classify type 1, type 2, type 3, I don't remember them. It's not important to remember. What is important, that true echogenic bowel versus false echogenic bowel. For that you have to completely lower down your gain, and even you can switch off harmonics and see if it stands out against the bone, then it is echogenic bowel. Otherwise it is just, and you have to do with certain transducer frequency of 3 to 5. If you are doing a higher frequency like transvaginal scan at 12 megahertz or something, you will see accentuated echogenicity. Whenever you do TVS, you will see this accentuated echogenicity, but those are normal actually. So 7% cases they are associated with those persistent echogenic bowel I am talking about, they are associated with trisomy 21. But whenever you see echogenic bowel, again the exercise should be, you must think of, apart from aneuploidy, a viral infection, cystic fibrosis, uteroplacental insufficiency, and GI pathology. So this checklist should be there in your mind whenever you are seeing this. And another thumb rule, echogenic bowel, look for the gallbladder, because echogenic bowel plus non-visualization of gallbladder, that is a hint for cystic fibrosis, persistently non-visualization of the gallbladder. So this is something like that will help you to rule out or screen for cystic fibrosis. Trap is your high frequency transducers, high dynamic contrast, like you are doing in an echo preset. Suddenly in an echo preset you start looking at the bowel, and then you see everything shining. So that is actually trap. And third trimester, sometimes because of the meconium, you will see brightness. Okay. And pathological conditions like meconium peritonitis, they are pathological, but sometimes you may mistake that pathology from just a kind of benign echogenic bowel, but those are actually calcifications. They are not just simple brightness, they are calcified, which is meconium peritonitis. and they have got a different outcome. So these things you have to keep in mind. Ventriculomegaly, I have I think discussed with you. They may be normal variant or they may be outcome of all these conditions. Will not go into detail. But as far as genetics is concerned, if it is isolated, the isolated likelihood ratio is 3.81. So you have to modify your risk by 3.81 if it is isolated. Like in this case, how to measure? We know how to measure, because here also measurement is key. Most of the time when it is borderline, like 9, 10, 11, they are measurement errors. So you have to measure them in a plane where you see your parieto-occipital sulcus and their perpendicular measurement on to on. Okay, so there are all these criterias. So we need not discuss in this slide, but there are criterias and you have to follow them so that you are sure that it is not a false ventriculomegaly. And apart from this trisomies associated with ventriculomegaly, there are a whole list of non-chromosomal disorders also. And the incremental is, if you read this paper, this is a very nice paper, what to tell to the prospective parents. In this, the incremental yield of CMA in isolated mild ventriculomegaly was 7% and whole exome was 13%. But obviously, if they are associated with multi-system abnormality, that went up as high as 33%. And in 2% of the cases, you have to rule out infection. So this slide I think we can discuss in the CNS when we are discussing ventriculomegaly, but just the genetic aspect and why it is important if you see a ventriculomegaly to do a CMA, that you can understand from this paper, and I will suggest that you go and read this paper. There are a lot of other information hidden in this paper. Now the last slide, that generally this is all the recommendations of SMFM, no need to go through that. If your NIPS is negative but you are seeing, USM stands for ultrasound soft markers, if your soft marker is present, then most of the societies they say no further aneuploidy evaluation is needed. Yes, but yes, when you discuss about that stronger soft markers like absent or hypoplastic nasal bone, then you have to, I think, go an extra step to counsel them that though I am saying this, but then we don't know, there may be some other chromosomal abnormality, and the best answer we'll get from the diagnostic test, because it's not only about ECOG or SMFM, there is ECOG also, there are some local societies also. Okay, and in case if FTS negative, okay, FTS negative but ultrasound soft marker you are seeing, then in all those cases you have to refine your risk based on the calculation, and then you have to provide them a follow-up option with NIPS or diagnostic invasive prenatal testing, because we have discussed based on the modified risk, if it is in intermediate risk category we can offer them NIPS, if it is in high risk category then we have to offer them a diagnostic test. And then all we have discussed, echogenic intracardiac focus, isolated echogenic bowel, isolated single umbilical artery, isolated urinary tract dilatation, and isolated short long bones, what to do with it. So that's why I said it's a kind of template. If you have those things in your mind, you can understand and you can report, or you can talk to the patient, counsel them in a better manner. Because see, the soft markers, there are a lot of articles written everywhere. Now sometimes you are stuck that you don't know exactly what points to mention to the patient. That's why I made all these slides, I kept all these points so that it will be a ready reckoner to counsel the patients. Thank you so much.